Hi, my name is Dr. Daniel Reeders. I'm a board certified cardiologist, been practicing for 4 decades. I practice currently in the San Francisco Bay Area and have several um, roles as a cardiologist. In fact, this week I'm at a teaching hospital, teaching doctors that are interns and residents, and they're training their clinical cardiology as their attending physician. This presentation is not meant to be giving medical advice. It's just observations, and sometimes I don't say things so perfectly well. So let me back up a little bit. Um, when I see patients with coronary artery disease, okay, let's back up a little bit. There's a concept that if the arteries that feed the heart are normal, you will not develop heart attacks, or the ones that um, feed the heart, you'll be not likely to develop a stroke. So, part of what we're talking about is vascular medicine, vascular biology, keeping the arteries that feed our vital organs healthy. And so, this is what we're looking at. When people are born, they're born without plaque. So, the plaque lives inside the vessel walls, and the vessel walls tend to grow outward when as they get this plaque inside, and then they grow inwards, and then what happens is they slowly impinge upon the blood flow eventually. And the real danger is not the critical stenosis that is slowly growing. It's when these vessel inside their walls, the blood flow facing part of the wall, not the outside of the wall, when they crack open, they do that, and then they heal. They crack open and heal over decades until they finally crack open enough that the biology, all of a sudden, with this open plaque, a blood clot forms, and then a cardiac catastrophe can occur, or a stroke. A cardiac catastrophe could be a heart attack, almost a heart, or a small heart attack where you have time to go get medical care, or sudden cardiac death syndrome, which is the number one killer in North America and around the world. So when I see patients, there's three different categories, just to split it up. There's the patient I see in the hospital that has a heart attack or an impending heart attack. These patients have what we call acute coronary syndrome, non-STEMI, non-ST segment elevation MI, a STEMI, ST segment elevation MI. So the STEMIs go straight to the cath lab usually to get a life-saving stent from the emergency room. The non-STEMIs go to the cath lab. Usually they don't go right away. They get put on blood thinners and then go to the lab when it suits the logistics of the lab, depending on their clinical presentation. So these are people that are unstable. They have symptoms, they're in an acute situation, and these patients generally need to go, all of them, to the cath lab unless there's a reason not to. At least that's my thinking. And then they go in and get a stent or whatever, or bypass. However, in clinical medicine here in the hospital and in the clinics, this thinking, let's not sound critical, so let's remove this from the dialogue, is flawed, because they don't treat the underlying disease, the underlying unstable, vulnerable plaque that's ruptured or going to rupture again, and it really doesn't, going to the cath lab and getting these things done does not directly account for that, does not see it, does not address it. I remember a study I was involved with decades ago where we we monitored their electrocardiogram, and then we counted out, we measured how much ST segment and T wave, their EKG changes, and most of those in these unstable patients were silent, and even the silent ones had huge meaning. They were not good versus the patients that didn't have these ST segment changes, unstable patients. So let's re-summarize. Unstable patients have unstable plaque. And this is a type of soft plaque that ruptures, and it's called vulnerable plaque. And so this is where the main focus of this presentation is. I did a previous YouTube, you can check on my channel, outlining many parts of this. So let's move forward a little bit. And then there's the unstable group. There's the stable group. They have chest pain, it's stable, they are on medications, and they're doing apparently just fine. And then there's the huge iceberg, under the water iceberg of more patients that have plaque that could be that is certainly silent and asymptomatic, and a lot of these can have unstable plaque, and a lot of soft plaque, which is unstable plaque is a form of soft plaque, or hard plaque and fibrotic plaque, which are basically a plaque that's trying to heal. And the thinking is that we turn the soft or and vulnerable plaque into hard plaque, and that's not necessarily so. Hard plaque inside our arteries, they make them stiff and non-pliable, and the blood flow is impaired, and it creates a whole new problem. So we would, in the best of the world, not have turned soft plaque into hard plaque, although this is a thinking in cardiology. I have one or two more points before we really start the talk. So there was two important studies in clinical medicine. One was called the Courage trial about 2 decades ago, and more recently the ischemia study. These were done in stable patients, not unstable patients, and they showed that if there, as a way to treat, so doctors would go in and decide whether to put a stent in, that in stable patients that come to the cath lab, they don't necessarily have an advantage on the table to put a stent in, that we can implement what they call standard medical care, or GDMT, guideline directed medical therapy. That's every modern doctor knows, do GDMT. And the GDMT, it's based upon clinical trials. Some of them are huge clinical trials, randomized clinical trials, RCTs, and double-blinded. And this is the gold in medical evidence. However, most of what we do in clinical medicine is not guided by that. So the trend in current clinical medicine, particularly cardiology, is to follow guidelines, get with the guidelines, and follow. And they use biomarkers that aren't as accurate as the biomarkers that we know now, but that's still the way the medical field is. And so what I'm trying to say is that unstable patients go to the cath lab, and the ones that are stable can go to the cath lab and don't necessarily need a stent right away. But these are totally two different animals, and that in every phase of this, the medical field, there's a huge gap, because at the bedside or in the clinic, even in the highest academic centers, they don't address the underlying cause, which we can get just a couple of blood tests or extensive blood tests to really find out what's going inside the vessel wall. And so that's what my hypothesis here and how I practice medicine and how I teach it to new doctors. And so that would be the background, in that randomized clinical trials tell us how to treat populations, and the hypothesis is thus then we have to treat individual patients this way, and this is better care. And so that's what's being legislated and become a rule, and they're never assessing vulnerable plaque, almost never, and treating that. And I think my hypothesis that there are a better way to do this. It's more than a hypothesis. This is personalized care. And when we do this, there's studies that have shown that patients undergoing stents or bypass surgery, which bypasses the problem, doesn't fix anything, they do better when we address the underlying pathology, the vulnerable plaque and the soft plaque. So also in clinical medicine, a big pharma, they look at biomarkers and they develop a drug that affects the biomarker. They have a hypothesis, and then they do a big trial and show that in real life, measuring these other outcomes like death, heart attack, strokes, and important items like that, that following this logic that they fix the biomarker, they just generally have built this huge conceptual practice framework, which all the insurance companies follow and academic institutions teach, don't address the underlying disease. But we can take advantage of biomarker, and these are surrogates. We don't have to keep doing cardiac catheterization on patients or waiting for heart attacks and strokes to find out what's good or not good. We can follow the biomarkers. And biomarkers are followed in clinical medicine and in the hospital and in the clinic. That's why they check cholesterol levels, blood pressure, stop smoking, these kind of things. So, believe it or not, what we eat and how we live our life affects our health. It's just not translating effectively to the bedside, my personal opinion, and I'm sure this can be something you've experienced or a family member or a friend. So there's this other concept in medicine, and I don't want to be offensive here and sound it, and it's absurd. So you come into the hospital or go see a doctor, cardiologist, and they lower your LDL calculated down to a very low level, let's say 30, which is often the goal in someone who has had a cardiac event, who's a high-risk patient. And then they come up with a concept that once they do that, they've done their work, and that now 20-25% of the risk is gone, and that everybody else goes ahead and treats what they call residual risk, which is 75-80%. However, this is a gap in care that I've noticed in the hospital and in the clinics and in the offices, that this isn't effectively being addressed. And so the fact that the medical community is treating 20% of the risk and says the rest is residual is upside down absurd. And it depends on what number you do to look at this number. In this particular slide, they call it 70%. So that's upside down thinking. See my previous YouTube. And so this one is particularly about residual inflammatory risk, not all of the risk. So even in the hospital, I have problems getting the residents, interns to, or my fellow cardiologists to order simple things. So if you asked a question, calculated LDL, which is what everybody follows and measures, and it's the GDMT thing. If you ask academics or wherever, or look at the science, what's more predictive? An ApoB, which measures all the atherosclerogenic particles, or an LDLC, what's more predictive? The answer always is the ApoB, and it's not measured. A lot of people don't even know what it is. And if you ask the same question a different way, what's more predictive, an LDLC, LDL calculated, or a HSCRP, high sensitive CRP? The answer is the HSCRP is more predictive than an LDLC, and it's never measured or hardly ever measured. So these are two tests that are easy to measure. And then another inflammatory marker is LP Plaque 2, PLA2, and MPO. These may be a bridge too far to push the residents, interns, and my colleagues to measure, and the LP-PLA2 measures inflammation. CRP measures the inflammation all over your body, and the LP-PLA2 measured it particularly within the vessel wall. The MPO, and also another one called MMP9, which we can't always get from certain labs, are even more specific and more scary to me, because inflammation is the main driver for vulnerable plaque. That is the main driver of that 20%, let's call it. We can say that of the other 80%, maybe 40% is due to inflammation, and maybe 30% is due to metabolic factors, just depending on how you cut the pie. And then there's other things. And I'm assuming that the blood pressure is being controlled, the patient's not smoking, which isn't always possible, either of those. This is just looking at the biomarkers, and those are biomarkers: smoking, obesity, high blood pressure. And then so that's the most important, inflammation, and its closely related friend, oxidative stress. And then the next one is the metabolic health, which is number 2, and one of the major markers of that is hemoglobin A1C, fasting blood sugar, and fasting insulin, and other markers. And then of importance are the atherogenic particles, and we have more accurate ways of looking at that. So in everybody, I get an ApoB, and when I order labs, I get at least once a lipoprotein A, which is 6 times, in some frameworks, more dangerous than LDL-C. And there's a specific marker called small dense LDL. And so that is particularly dangerous because it's a small particle that can go straight into the vessel wall. The larger particles have a harder time. So one of the ways we treat small dense LDL, number one, is we decrease the particle number. So if they're high, we put them on or do things to decrease that number. And the other way is that the way we make small particles larger is by treating their metabolic disorders. So these are mechanistically linked. And then this lipoprotein A is really bad. It can cause blindness, strokes, calcified cardiac valves, and heart attacks. So this is genetic. So we check this, and if someone has that, then we tell them to tell all their family members. It's incredibly important in that there's new drugs that are likely to be really groundbreaking in terms of the treatment. So in my practice, I do HSCRP, ApoB, lipoprotein A, hemoglobin A1C, and some of these other markers depending on the situation. Look at also fasting blood sugar and um, insulin levels. It's really easy. The click on the record, and these are ordered, and then you have to know what to do with these. So, and I like the precision medicine because it identifies what we can accomplish in a patient or possibly accomplish and have markers we can check every 3 months and see if our intervention has worked or not worked. And that translates to better patient care. And so it's not always about a drug or a supplement or lifestyle. It's looking at the whole thing and putting all your good check marks from red that are bad to yellow that are yellow, and then to making them toward push them to get all the check marks toward green, the endothelial function, the inflammation, the metabolic disorder. And for instance, omega 3s. Your brain is about 10 to 15% by dry weight. One of the omega 3s called DHA. And its close relative, EPA, is one of the strongest anti inflammatories. And you can just check an omega level in the blood, another check. An important study that showed that Japanese people don't tend to historically get strokes or heart attacks. It's low. And they thought, well, it's because they eat fish, and when they come to North America, they get the same amount of heart attack and strokes. And one of the things is we check the omega levels, and in the United States, the normal is over 5.6. And most of the patients I check are way below that or significantly below that. I hardly ever see one. However, in the Japanese cohort in Japan, their levels are 8 or 9%. So we need to be more precise. And going back to eating a reasonable diet, a Mediterranean type diet, a colorful diet. And then we recommend exercise. Your doctors have to know what kind of exercise and where, and biomarkers can help you with that. And they tell you to reduce the stress and send it to the primary. But our medical teams train to treat inflammation, oxidative stress, endothelial function, the inside lining of the vessels called the glycocalyx. So we can be doing a lot better. And what about instead of putting someone on colchicine for inflammation and a statin drug promotes soft plaque into hard plaque. When they were designing the study that showed colchicine by decreasing inflammation was important and changed the outcome of a patient. I asked one of the people on the steering committees, a friend of mine, why not use curcumin and omegas? And they rolled their eyes at me. So they went pharma. The colchicines over here, typically used for gout and for pericarditis, for instance. And then there's newer drugs that don't don't promote calcified plaque, and they may decrease LP little a, lipoprotein A, and so there's all this new pharma coming out, and we have plenty of tools. We just need to know them and know who to push and pull what patient. If you have a patient that's inflammatory, you push on the inflammation. If they have high atherosclerogenic particles, you push there, intervene there. If it's metabolic, you push there, for instance. So if we don't look, we don't know. So we have evidence beyond randomized clinical trials which allow drugs to be patented and to tell us how to treat population, not individual patients. And in clinical medicine, at least it's evolved a little bit. We don't solely mainly rely on randomized clinical trial or expert opinion based upon markers that are not as accurate. So before we end this talk, I'd like to just say that there are certain markers that we can follow, and that some of the markers that are like a 911 for vulnerable plaque are elevated HSCRP. The higher, the worse. The troponins, if they're elevated, that's a signal to maybe go to the cath lab. And even a little elevated a troponin, which is leaked from the heart muscle. The elevated hemoglobin A1C, the LPPLA2 is important. There's other ones. The MPO, myeloperoxidase. Someone's smoking or has a positive drug screen, their blood pressure is out of control. The lipoprotein A, the higher the worse. We want to look at the numbers. The ApoB, the MMP9, which we can't always get and can't convince people and sometimes about it's important, but when they look at and do a search, they find out how important it is in the dementia world and in the kidney world and in the cardiac world. So we can each portion. So what happens is we have normal vessels and they turn into endothelial dysfunction. So we can evaluate endothelial function and treat that. And if your endothelium is well, then we don't have to worry about so much about the rest, because there's not going to be inflammation in the blood vessels and small particles entering. So we lower the particle numbers. And when particle numbers are in there, they promote more inflammation. We find out why a patient's inflamed. So you may not know, but a lot of the damage to blood vessels occur after we eat. So we got to make sure they have their gut is working well. It's not permeable, letting in very dangerous particles, the lipopolysaccharides (LPS), which are very inflammatory. Every time we eat, those can flood the systems in not a good gut, and this drives coronary artery disease and cerebrovascular disease. So we can assess with biomarkers where exactly we are treating a patient and where and how and where and how to push, whether inflammation or these other things where we need to focus, although they're mechanistically related. And then we get plaque formation, and it grows outside, and then it grows inside the vessel wall. And just because it's not 80% lesion that would need a stent doesn't mean it's not dangerous, because a 20% or 30% lesion can rupture and you can get a blood clot and then have a catastrophe like a stroke or heart attack or death. So we don't want to wait for those. And then so there's markers for soft plaque. And then these markers are similar for unstable plaque, vulnerable plaque, necrotic plaque. And the numbers go way up. So we want to to understand that. And so, and then there's markers that as invulnerable plaque turns to fibrotic plaque to hard plaque. But the main thing is to know when there's an emergency and not wait for a cardiac catastrophe, measure these markers, and that when someone's even in the midst of a catastrophe, that we address the markers that underlie that precisely can tell us what is going on and where to put our interventions effectively.